Hello students, welcome to this learning platform, and on this platform you'll find revisions, questions, explanation to difficult topics, a lot of stuff. So before we begin our lessons, make sure that you subscribe so that you can be updated to upcoming videos. To make this so short, let us begin. In this video, we are talking about what? Lower GI bleeding. Remember that in the previous video we talked about what? The upper GI bleeding. And if we talk about the bleeding, the GI bleeding, basically we're talking about the bleeding that can happen in any part of the what? GI tract. Okay, it can be either in the esophagus, the bleeding can be occur in the stomach, can occur in the small intestine, can occur in the large intestine. Okay, it can also occur in the anal canal. Okay, any part of the GI any part of the what? GI tract, then if the bleeding occurs, then it's going to be considered as what? GI bleeding. Remember we talked about the important classification of GI bleeding. We said the important anatomic classification is what we consider certain structure which we call what? The ligament of Treves. Ligament of Treves is basically a fibrous type of structure that comes from the what? Right crest of the diaphragm, and it's going to insert on the what? On the duodenal junction there. So that structure is very, very important to categorize the GI bleeding into what? The upper GI bleeding and also the lower GI bleeding. If you talk about the lower GI bleeding, is what? It's a bleeding that will happen below the ligament of what? Treves. Basically, it's going to include the what? The ileum, the jejunum, colon, the cecum, the anal canal, the rectum, everything, all those structures are going to be what? Involved there. If bleeding happens in those structures, basically are going to consider as what? Lower GI bleeding. Remember, lower GI bleeding is what? It's not that common compared to what? The upper GI bleeding. You need to remember that, okay? And so again, another important classification that we talked about, we said okay, GI bleeding can also further categorize apart from upper and lower. Can also use something else according to duration. Can be acute, chronic. Okay, can be maybe if you are able to see the blood, it can be occult, it can be ovate, it can be what? Obscure type of what? Bleeding. We talked about that. Okay, what we also talked about another what? Last classification. Okay, it can be moderate, mild, or severe type of what? Bleeding. All those things you need to what? Know them. Okay, now before we begin here talking about the lower GI bleeding, you need to understand something. Okay, you need to understand something. Remember, from the upper GI bleeding, what did we say? From the upper, we said to say someone can present with what? Okay, hematemesis. Okay, someone can present with what? Hematemesis, whereby someone is vomiting what? Fresh blood. Okay, hematemesis. What else? Someone can present with what? Melena. Okay, and someone can present with a coffee ground type of what? Vomiters. We talked about that. Okay, now it is very interesting to know that also in lower GI bleed, the most common presentation that we will be talking about is what? Hematochezia. Okay, this one, hematochezia, is one of the important feature or clinical feature that you need to be using to differentiate from the upper GI bleeding and what? Lower GI bleeding. If you see hematochezia, basically to indicate that lower GI bleeding, but there is what? An exception that I need to talk about. What is that an exception? So an exception is that also in upper GI bleeding, sometimes the upper GI bleeding can present with what? Hematochezia. But in what case? Because hematochezia was one of the important what? Clinical feature that we use to differentiate from upper and lower. But we see hematochezia also in what? In some cases of what? Upper GI bleeding. What those cases? Maybe someone is having what? Massive what? Upper GI what? Bleeding. They are bleeding severely. Basically, what's going to happen is that that bleeding is not going to have enough time. That is coming from the upper GI bleeding. Okay, it's coming from the upper GI tract there. Okay, it is not having enough time to be digested. So that blood that is coming from the upper, it's not having what? Enough time to be digested. If it is not having enough time to be digested, then it is removed via the what? The anal canal there from the rectum there. Then you are going to see what? Bright red type of what? Bleeding. And bright red type of bleeding coming from the anal canal is what? Hematochezia. But What about Medina? Medina basically is something that is not bright, it is what? Dark in color, okay? The reason why it is dark in color, I explain to say it's because of what? Those red blood cells were what? Partially digested in the what? In the stomach there, why it was converted into what? Into like the hemoglobin was converted into hematine. We talked about that, okay? You need to take note of that. So in summary, what we're saying is that hematochezia is not always in the what? Lower GI tract, okay, or lower type of GI bleeding, okay. It can also present in what? Upper GI bleeding when there is what? Severe, or the bleeding is severe in the what? Upper GI tract, okay. You need to take note of that. Now let's proceed to what? Lower GI bleeding. So lower GI bleeding, we're saying any bleeding. So we're saying bleeding arising from where? We know from what? Lower than what? The ligament of what? Trace. So arising from what? Now we let's just specify those structures. We're going to say it's arising from the what? Jejunum. Align, so jejunum J, okay, ileum, okay, I. What else? We said colon, okay. We have cecum there, also let's say rectum, and also anal canal. So those are the important what features that we need to talk about what bleeding from the like lower GI bleeding, okay. And remember that the structure that's going to tell you that this is lower GI bleeding is what? It is the ligament of what? Trace, the very important part, anatomic part, okay. Now since we know that, and remember that this lower GI bleeding is about what? 20% of what cases, not that common compared to what? The upper GI bleeding. You need to know that, okay. Now the question that you can ask is that what are the causes of what? Lower GI bleeding. What are those causes? Because it's very important to talk about that. Okay, so let's start with the first cause. So the first cause is what? Hemorrhoid. As you can see, this structure here, okay? This structure here, this is what? The anal canal, okay? The hemorrhoid also sometimes called what? The pars, okay? Hemorrhoids, they arise from the what? The anal canal there, okay. But there are basically different types of hemorrhoid, but let's just take it simple. There are what we call external hemorrhoid and what? Internal hemorrhoid. So these parts that we are talking about, you've seen this line, okay. This line separates the anal canal into the upper part and the lower part. What we call this? We call it what? Dentate line. Sometimes they use another name, which is pectinate what? Line, okay. Dentate line or pectinate line is a line that is very important, an anatomic line that is very important. That's going to separate what? The upper anal canal and what? Lower anal canal, okay. So these hemorrhoids that are arising from what? That are rising above the dentate line, what do we call them? We call them what? Internal. Internal what? Hemorrhoids. We call them what? Internal hemorrhoids. What about these that are rising below the dentate line? What do we call them? We call them external hemorrhoids. Okay? Internal hemorrhoid and external hemorrhoid, okay? According to this dentate line. So we're calling this line as what? Dentate. Dentate line, okay. Now if you look at this internal hemorrhoid, okay, this internal hemorrhoid can present somehow like what we call that? We call it painless type of what? Bright red bleeding. So it's going to present what? With painless what? Bleeding. So let's just say, since it is anal type of bleeding, what do we call that? We say that is hematochezia. Hematochezia basically is a bleeding that is bright red and it is coming from the what? Anal canal, okay? Unlike Medina, although it's coming from the anal canal, but it's not bright red, it is what? Dark in color. Why? Because it was digested in the stomach via the secretions, okay? Now, what are we saying here? We're saying this is what? Hematochezia. Okay, this is hematochezia. So they are going to present with what? Hematochezia. Basically, all the hemorrhoids they are going to present with what? Hematochezia. But basically, the type of hematochezia can be what? Painless. So this one is going to have what? Painless hematochezia. But sometimes, in case of what? Let me just put here I. That is for internal. Most of the time for internal, it is what? painless. Or no wonder they said painless bright red what the type of hematochezia. Okay, that's coming from the what internal what hemorrhoid. But this external hemorrhoid, you've seen this external hemorrhoid, the one that can be what you can even feed it with bulging on the what the anal canal there. You can feed it like that, okay, because it is external, it is below the what dentate line. Okay, so that is external hemorrhoid. But in case it is what thrombose, there is thrombosis to that what external hemorrhoid, then it can be what painful. No wonder sometimes it's not always all the hemorrhoids are going to be painless, but if the thrombosis happens on the what external hemorrhoid, what's going to happen? There'll be what pain. So also we're going to say painful. In case of what? In case of what thrombosis. So let's say in case of what thrombosed. Let's say thrombosis. In case of what thrombosis, okay, they are thrombosed. Those external hemorrhoids, they are what they are undergoing what thrombosis. Then they are going to become what painful. Okay. Okay. Now the other important thing is that okay, the type of bleeding is also sometimes for internal hemorrhage. It is what intermittent. Okay, intermittent. Sorry. Okay, it's what intermittent. Okay, from the internal hemorrhoid. So it comes out like that. But how do you know that okay, this bleeding is coming? Since if you look at the internal hemorrhoid, it's not that what can I say? You can't you can't see the bulging of that hemorrhoid coming out like that. But you can see at least some certain bleeding on the what on the toilet paper. So if you see that, basically you can suspect that okay, that's an internal hemorrhoid, though you are not feeling it. But if you can see it on the what toilet paper, basically you can suspect what hemorrhoid. Okay, very important part. Now, a question that you can ask is that what could cause this hemorrhoid that we're talking about? What could cause that? Okay, the first important cause of that is what? So let's talk about these causes. Someone, it has been related to what we call chronic what constipation. Let's say chronic C. Chronic constipation. Someone has chronic constipation, they are at increased risk of developing what hemorrhoids. Okay. What else apart from that? Also, another relationship is it has been shown that pregnant women, so pregnancy is very important to what risk factor. Okay, that one can also predispose someone to what hemorrhoids. What else? Also obesity. Okay, obesity has been shown also to cause what okay, hemorrhoid as well. Okay, now since we have at least this what relationship to what someone developing what hemorrhoid. Okay, now to be more specific, what are those hemorrhoids? We know that okay, these are basically we have two types, but what are these hemorrhoids that we're talking about? Those hemorrhoids basically those are what dilated veins. Okay, those are dilated venous plexus in the what anal canal. They are dilated. The reason why they are dilated is because of what? It's because someone maybe is obese, chronic what constipation, pregnancy. Okay, straining while at bowel movement. So straining while at during bowel movement like that is straining. Those they are going to increase intra-abdominal pressure, causing what? Dilated veins. Okay, so here they are going to be dilated. This either internal or external, they're going to be dilated. If they are dilated, what do I expect? They're going to rupture at some point. If they rupture, they are going to release what? Blood. Basically, it's going to present as what? Hematochezia. That's under what? That's under hemorrhoid. You need to understand about that. Okay. Now we go to another one. This one. Okay. What is this? So this is what we call what? Diverticular disease. So what do we call this? We call it what? Diverticular disease. So this diverticular disease is common in what? Elderly. So very important point to take note of. We are saying this is common in what? Elderly. So it is common in elderly. Okay. Now, what is this diverticular disease? So this diverticular disease basically is what? Basically, it is the type of disease that's going to form what? Small pouches that are going to the what? Colonic hole. Because basically this is the colon. So these pouches, they are coming out because there's a weak point where that normal line of the colon is what? forming pouches, those smaller pouches. Okay, so what are we saying? We are saying this is the colon because of there are some certain weakness in the colon there. Okay, those weakness, that's why the colon itself is going to form pouches, but basically those are what we call smaller pouches because of that weak point in the colonic wall. That is what we call diverticular disease. The question that you can ask is that why is someone having a diverticular disease? Why? Because the first point we said that the risk factors. So why someone is having that? The first point is what? Elderly, okay? Advanced age, like that, okay? What is the other important feature? It is because maybe they're having chronic constipation. They're having chronic constipation. What is the last important feature that you can talk about or relate with? Low fiber diet. Let's just say low FD. It is low fiber diet. So these are the important factors that are going to predispose someone to have diverticular disease. Basically, those small outpouching things, okay, that are going to the colonic or due to some certain weakness. Remember that the weakness that we're talking about is where the blood vessels cross the muscular layer of the colon. Okay, so that's where the weak point is. So that's where those pouches they are going to arise from. Okay, that's what we're talking about. Okay, and the reason why someone is having that, we say that is because of they are having the chronic constipation. That's going to increase the intraluminal pressure, causing those outpouching things or structures that are going to occur there. So that's the thing about that. Okay, now what is the other important feature? What are the clinical features of that? Okay, what are the clinical features of someone having diverticular disease? What is that? The first one is we know that is hematochezia. We know this is the first one, and basically the hematochezia is painless. Also an important feature. The hematochezia is painless, okay, and basically it is self-limiting. So this disease basically is self-limiting, unless this pouching, this pouching they rupture. The moment they rupture, they are going to cause massive type of bleeding, or which is hematochezia, massive hematochezia. So you need to intervene and see such thing. Okay, very, very important. So they are going for hematochezia, which is painless. Okay, but it can be painful once those outpouching they rupture. So what are we saying? Painful when these pouches rupture. It may be painful, okay, because it's going to cause massive type of bleeding. Very, very important point to take note of. Okay, so now let's go to another one. Apart from that, let's go to this one. You've seen this one. What is this? Okay, let's talk about now the inflammatory bowel disease. So let's talk about IBD. Here we're talking about IBD, inflammatory bowel disease. Remember that inflammatory bowel disease, it has how many conditions? It has two types of condition. What are those? There's what we call ulcerative colitis and Crohn's disease. So this is going to have two. It's going to have ulcerative colitis and Crohn's disease. Two important diseases that are there. Okay, is okay. So now, if we talk about this IBD, this one of the causes of lower GI bleeding. Very, very important. Remember that if you talk about ulcerative colitis, okay, ulcerative colitis, basically most of the time it likes to affect the large intestine, basically the colon. Okay, starting from the rectum up to maybe the transverse colon somewhere there. That's why it likes affecting, and basically it's going to cause superficial ulcers. Okay. Now, if we talk about Crohn's disease doesn't choose that. Okay, I'm going to be affecting the large intestine. I'll be affecting the small intestine like that. It can affect any part of GI tract. Okay, but basically it like sometimes it is most common in the distal ileum there, okay, or the right colon there. So that's why it likes to affect, but it can affect the any part of the GI tract. So that's about Crohn's disease, and it causes deep ulcers if you look at that. Okay, now since we know the major categories of what IBD. Now, what are the clinical features? Okay, what are the clinical features of this? So these ones, they are very, very important. The first one is what? It is associated with what? Abdominal so let's just say abdominal pain. It is associated with what? Abdominal pain, because those are ulcers. Someone is going to be feeling what? Abdominal pain or low abdominal tenderness. They are going to be feeling that. Okay. What else? So the other important clinical feature is that they are going to have what we call blood diarrhea. Okay. Blood diarrhea, very, very important. Okay. Blood diarrhea associated with what? Abdominal pain. What else? They are also going to have what? Tenesmus. Tenesmus, basically that sensation of what? Incomplete defecation. Okay. And what else apart from that? They are going to be having urgency. Okay, urgency. So a lot of clinical features that can present with what? IBD. A lot of them. What is the other important clinical feature that you can also take note? They can also present with what? Systemic type of what? Clinical features like what? They can present with weight loss. They can have what? Weight loss. Okay, they can have malaise. Okay, so let's just say malaise. Very, very important. Okay, very, very important. Malaise like that. Okay, so those are the important clinical features of what? IBD. So what do we say if we come back here? So this IBD, we know that the ulcerative colitis, what did we say? We said that it likes to start from what? The rectum there, okay, going up to maybe affecting this large intestine, up to maybe this transverse colon there. Okay, it can affect like that. It goes like this, starting from here going like that. Okay, then causing blood diarrhea like that and abdominal pain. But if you talk about the Crohn's disease, it doesn't like, but it likes most of the time the what? The ileum like that, the distal ileum or the ascending what? Colon like that. Okay, it can affect like that, or the cecum. So that's where the Crohn's disease likes to affect, but it can affect what? Any part of the GIT. And remember the types of ulcers that they cause. This Crohn's disease, they can affect, they can produce what? Deep ulcers because of what? The transmural type of what? Inflammation under Crohn's disease. This one, they are going to have what? Superficial type of what? Ulcers. So these are the clinical features that are very, very important under what? Crohn's disease and what? Ulcerative colitis. Very, very important. You need to know that. Okay. Now let's go to another one. So what is this? You've seen this one. So what is this? This one is a very, very important part as well. It's one of the causes of what? Lower GI bleeding. What is this? We call it angiodysplasia. So what do we call this? We call it angiodysplasia. So this is called what? Angiodysplasia. So what is angiodysplasia? So angiodysplasia, this one, just from the word angio, basically they are talking about what? Blood vessels. So malformation of what? Blood vessels, okay? Basically, sometimes it is called what? Vesicular malformation. So in bracket, let's just put what? Vesicular what? Malformation. So let's just say V malformation. So in this type of a disease, the vesicular what? Malformation. In this type of a disease, you've seen these blood vessels. These blood vessels are what? Fragile. Okay, they are very fragile like that. They are very weak, whereby they can what? Anything, maybe anything that's going to increase the what? Intra-abdominal pressure or intra-abdominal pressure there. What's going to happen? They're going to what? Make sure that those blood vessels, they're going to get what? Ruptured and what? Cause what? Hematochezia or bleeding. Very, very important concept. Okay, so now the question that you can ask is that angiodysplasia is common in what? It's common in what? Elderly. Okay, so this is common in what? Elderly. Okay, common in what? Elderly. Very, very important, angiodysplasia. Okay, what else? Now this part, so basically this should be what? It is common in what? In the colon. Okay, it is common in the what? Colon. Basically in the right what? Colon. That's why it can what? You can find it angiodysplasia. Okay, then what else? So this angiodysplasia, basically, okay, it's going to show what we call an intermediate type of bleeding. So they are going to have what? Hematochezia okay, which is what intermittent, okay. This one they are going to have what intermittent type of what bleeding, okay. So intermittent type of what bleeding, and it is what painless. Very, very important what points to take note, okay. So remember that, okay, sometimes this dysplasia can also have massive type of what hematochezia, or type of what bleeding. If these blood vessels they rupture, okay, if they rupture so severe, they are going to cause what severe type of what bleeding. Basically, that's what about what dysplasia, okay. Basically, what we've said from talking about is that dysplasia is what is common in elderly, and it presents with what intermittent type of what hematochezia, and it is what penis, and it's common what elder. Very, very important point to take note of that, okay. And basically that's because of what vesicular malformation in the colon. What did we say? Why is it common in the right colon there? So that's why you can see those malformation of blood vessels there, okay, that are prone to what to bleeding, because they are fragile, they are malformed, okay. So that's about dysplasia, okay. Now there's also another important point another cause that you need to take note of, okay. What is the other important cause? This one, CRC, okay. What is CRC? Colorectal cancer. Colorectal cancer is also one of the important cause of this lower GI bleeding, okay. So that's the cancer of what? That's the cancer of the rectum and the colon. This one is a very, very important cause of that, okay. Now, for someone to develop this one, if you talk about the clinical features, so we'll come and talk about the risk factors. So if you talk about the clinical features, they're going to have what we call this type of bleeding. This is what we call occult bleeding. You need to take note of this. So occult bleeding, so it is often seen in someone with colorectal cancer, okay. Now, what is this occult bleeding? So remember that occult bleeding is a type of bleeding where you can't see the bleeding, it is hidden. You can't see it with your naked eyes, unless maybe they use a certain test which we call fecal occult test or blood test. So fecal occult test. So what are we saying? Occult bleeding can only be detected by a certain blood test which we call fecal occult blood test. It can be detected in such test, and it's going to be positive. So the bleeding, you can't see it in the fecal there, so you can't see it there, okay. In the stool you can't see it, but for you to see it, you need to do a blood test. This one, the fecal occult blood test. That's when you are going to see the bleeding, okay. It's going to be positive. If it's positive, then it's going to tell you that there's something that is going on, okay. And it has been shown that this one occult bleeding is related to anemia, okay. Anemia. Basically, they say that has to do with microcytic anemia, okay, or iron deficiency anemia, some stuff like that, okay. So you need to know that, okay, occult bleeding is common related with anemia, okay. What else apart from that? Someone with cancer, we know that they are going to have weight loss, okay. They are going to have weight loss, okay. They are going to have malaise, okay. Sometimes they also present with abdominal pain. These people are going to present with abdominal pain, but the type of bleeding, the type of hematochezia is occult, okay, something that you can't see with your naked eyes, okay. Now the question that you can ask is that, what are those people that are going to develop colorectal carcinoma or cancer? So why are they developing colorectal cancer? Why? So the important part is because they are elderly. Basically, it has been estimated that it is greater than patient greater than 50 years, okay. And what else? The other risk factor is that a patient with previous like family history of colorectal carcinoma or cancer, okay. Family history of that. So let's put it here. Family history of of CRC, okay. Family history of that, and also maybe if they had polyps, okay, history of polyps. If they had polyps like that, they had polyps. So history of polyps like that. So greater than 50 years, family history of colorectal carcinoma or cancer, and history of what? Polyps. So those people that are at increased risk of what? Having the colorectal cancer. Although there are other risk factors that are there, okay? But basically these are major what? Risk factors. They are a lot. Okay, so that's about the colorectal carcinoma, okay? The cancer of the rectum and the cancer of the colon, okay? So these are the important points that you can take note of. And the other important cause, apart from colorectal cancer, there is also what we call colitis, okay? There is what we call, so let's talk about the last one here. Let's talk about what? Colitis. Okay, so colitis can be infectious colitis, or ischemic what? Colitis. So basically, colitis, we're talking about the inflammation to the what? Colon. So the inflammation can be either coming from what? Because of there is a bacteria there, or maybe there is what? There is no blood supply to the what? The colon, causing what? Inflammation to the colon. Basically, that would be what? Ischemic what? Colitis. So there is ischemic colitis and the what? Infectious colitis. And these are also causes of what? Causes of what can I say? Lower GI what? Bleeding, this one. So infections like what? Infections like you can have Shigella, you can have Salmonella, you can have Campylobacter, all those type of infections, okay? Infectious or microorganisms, they can cause what? Colitis, okay? Or infectious colitis. So those. So regardless of that, what could be the presentation? Someone coming with the infectious colitis. Basically, if there's an infection, we know that there'll be what? Fever, weight loss, malaise, all those things, okay? And also, since this is an inflammation, there'll be what? Abdominal tenderness or abdominal pain, all those things, blood diarrhea, okay? There'll be one of those clinical features that you can see from what? From the clinical features. Those are the things that you can see, okay? Under colitis. Also, same applies to ischemic. Ischemic type of what colitis is what? You can see blood diarrhea as well. You can see abdominal tenderness. You can see like fever as well. Somehow fever, it can be there, okay? A lot of what the clinical features that you can see as well, okay? In general, what we're saying is that here the ischemic colitis present most of the time what? Blood diarrhea, okay? You can have blood diarrhea like inflammatory bowel disease. So those are important what? Causes of what? Lower GI bleeding, okay? And the other important thing that we left on here is under angiodysplasia. So angiodysplasia, another important clinical feature that we left was what? That was, it is somehow related with aortic stenosis, okay? It is somehow related with what? Aortic stenosis, okay? So someone with aortic stenosis, basically you can tell that, okay, somehow they can have angiodysplasia, okay, that one. So it has some relationship with that, okay? Make sure you need to understand that, okay? Now we are, let's talk about now the diagnosis. Someone coming with either the upper GI bleeding or the lower GI bleeding. How can you investigate that patient? So the first thing that you can do is what? You do history, okay? You ask you ask about the bleeding that they're having. If they're able to see like that, symptoms of anemia, you need to ask about that. The agement, because there are different types of what? Causes. You need to ask a lot from history based on the what? Clinical causes of what? Of the upper or the lower GI bleeding. You need to be asking a lot of questions, okay? From history. Then if you look at the exam, the exam someone comes with what? GI bleeding like that. What are you going to do? Basically, what you need to do is first you perform what? The general exam. You see the appearance of the patient like that, okay? Are they having altered mental status like that? You look at all those things, okay? You do all the exam, the abdominal, the GI exam, you do it. You do a respiratory exam, you do the cardiovascular exam, you all do that, okay? So in that case, we're going to at least from the history and the exam, you're able to what? At least to pick the specific what? Cause of that GI bleeding, either the upper or the lower GI bleeding. So you need to do the history and the what? GI and also the what? The exams for you to have what? At least the diagnosis according to the clinical features that we from what? Talking about. Basically, you need to be more specific, okay? So that's about the history and the exam. Now the most important thing is what? Investigation. That's why you are going to be assessed, okay? History and exam somehow quite right, they are going to help you to come up with what a diagnosis. But basically, you need to also know about what investigation. So investigation, we talk about the laboratory investigation. We talk about the imaging modality that they use, okay, and also the treatment what modality. Okay, so let's start with what laboratory type of what investigation. So what are those? First of all, we know that the first important thing is what you do the complete blood count or full blood what count. Okay, FBC. So full blood count. What are you? Why are you doing full blood count? Because you need to assess what anemia. Remember these people, they are what bleeding. If they are bleeding, they are going to have what anemia. Okay. What else? You are going to do liver function what test. Liver function test. Basically, you are assessing okay, the function of the liver like that. Okay, basically, if they're having low blood volume there because they are bleeding, basically you are going to have what defect or problem with the liver. Okay, so you do liver functional test like that. Also, another important thing, you also need to do the coagulation profile. Okay, where the international normalizing ratio is going to be what prolonged. So we're saying also do what coagulation profile like that. Coagulation profile. So coagulation profile, you're going to notice that the INR is going to be what prolonged. You need to do that, okay? Because under coagulation profile, you are going to see the prothrombin time, partial thromboplastin time, all those things are going to be what prolonged, okay? The D-dimers are going to see all those things, okay? Very, very important. And the other important aspect is what? You need to do urea and what? So let's just say urea and what? Creatine. So let's just say you see urea and creatine, they are going to be what? Elevated. This one particularly is very, very important. You need to take note of this. So this one is what? Elevated in what? It's going to be increased in what? Upper GI bleeding. Okay, upper GI what? Bleeding. So the question that you can ask is that why is there is elevation of urea and creatine in upper GI bleeding, while you see in the lower GI bleeding, quite right, they can be in normal ranges, or maybe they can be what decreased like that. Why? So why in upper? It's because of if you look at the blood, someone who is bleeding, basically in blood there is what? There are proteins there. The proteins there, basically that since that is the upper, remember that they're going to be digested there. Okay, they're going to be broken down into what? Some components. Remember that proteins, if they are broken down, basically you're going to have what? Urea there, urea production. Okay, from proteins. Proteins are being broken down in the stomach. Then those end product of protein digestion, they're going to be what? Absorbed into the what? Bloodstream. If they absorb, basically those are the proteins that were initially broken down. Basically, you're going to have what? Now urea formation. No wonder if you look at in the upper GI, you are going to expect the urea levels and creatine level to be what? Elevated because of what? Protein breaking down. You need to understand that, okay? So apart from these important laboratory tests, you can also do the renal functional tests. You can do that, okay? So apart from these laboratory tests, what else are you supposed to do? So you need to do also this important procedure, endoscopy. So you need to do endoscopy, okay? So endoscopy is very, very important in assessing something, okay? So they use what we call upper endoscopy for what? Upper GI bleeding, and it's a gold standard what type of diagnostic what procedure. So what are you supposed to use here? So they like asking this question, the upper endoscopy. So let's just say endoscopy, upper endoscopy, okay? Upper endoscopy for what? Upper GI bleeding, okay? It's a gold standard procedure that you need to do, because this one upper endoscopy. So the endoscopy is also going to help you to treat the cause. You find out the source of what bleeding using the endoscopy, and if you find out like that, you're going to to treat it using the endoscopy, the same instrument, okay? So that's why it's very, very important. But before you do endoscopy, basically you need to stabilize the patient, and it is done 24 hours, okay? After 24 hours after stabilization, okay? Within 24 hours, it's going to be done, that procedure. Very, very important, okay? Very, very, very important. What else? So you can do what? The other one is you can do colonoscopy. colonoscopy. So colonoscopy, you can do it as well for what? Now this one, colonoscopy, you do it for what? Lower GI bleeding. It's a gold standard procedure. Okay, colonoscopy. Okay, you do that. So this one as well, for you to do colonoscopy, basically you are going to be assessed on this one. You need to first stabilize the patient. So those initial stabilization that we always do, you do the ABCs. Then after that, the patient, if the patient is stabilized, then that's when you can do what, the colonoscopy. Okay, so that you can find out now the source of what, bleeding, and treat it. Okay. Then the other important investigation that you can do apart from endoscopy, these are laboratory tests and also colonoscopy. You can also do imaging. Okay, the one that I wrote here. So imaging, you can do them. Okay, imaging like what? So you can do what? Imaging like what? So let's put imaging here. Imaging. So you can do imaging like what? So you can do CT angiography. Okay, you can do CT angiography, or there is also another one. Okay, red blood cell, tagged red blood cell scan. So tagged red blood cell scan. So these are the important imaging that you can do. Okay, so if you look at the CT angiograph, so CT angiography can only be done when what? When you can't find the source of what? Bleeding. Basically, what do you say if you talk about the type of bleeding where you can't find the what? The source of bleeding. What do you say? That was what? Obscure type of what? Bleeding. So CT angiography basically it is what? Used in what? Type of what? Bleeding, which we call obscure type of bleeding, where you can't find the source. After what? Normal procedures like what? You did colonoscopy and endoscopy, but you didn't find the source, then you can do what? Imaging like what? CT angiography. This one is very, very important in such what? In such type of what? Conditions. Now, what about the tagged red blood cell scan? When is it what? When is it important? It is important if the CT angiography is also not what? Showing the source of what? Bleeding. Basically, like the type of what we call intermediate type of what? Bleeding. The intermediate type of bleeding is so what? Difficult to find the source where it is coming from. If the CT scan fails, then after endoscopy and also colonoscopy, then what are you going to do? Now you can do what? The tagged red blood cell scan. This one is going to what? To show those what? Type of what? Intermediate. So let's say intermediate type of what? Bleeding. After the CT scan fails to what? To find out the source of that intermediate what? Type of bleeding. Very, very important. You need to know that. Okay. Now, so those are the investigations that you can do. Now you can do. Let us go to what? Treatment what? Modality, so that we can be done with this. Okay. So treatment modality. What is that? So what is the first thing? The first thing that we need to do is what? We know someone is coming with what? GI bleeding. They're what? They are like hemodynamic and stable. What are you going to do? Stabilize them by using what? ABCs. So the first so you do initial management by doing what? By doing what we call ABCs. Okay, you do ABCs, airway, breathing, then circulation, do all those things. Okay, you try to stabilize that patient. Okay, then after you stabilize the patient, what are you going to do now? The other important thing is what you can do, and the other important you can do pharmacological treatment management. So let's just say pharmacological management. You can do pharmacological management like what? So you can use proton pump inhibitors or PPIs. Proton pump what? Inhibitors like that, like what? So proton pump inhibitors like what? Omeprazole. Okay. Omeprazole is a very, very important proton pump inhibitor. Okay, that's a drug that they like using. What else apart from that? The other one is we have this one. Okay, this one. So octreotide. So octreotide is a very, very important drug which is used in what? Esophageal varices. Okay, because it's going to decrease the portal pressure there. Okay, remember that esophageal varices it was because of what, the portal hypertension that was causing the bulging, or the what, the increase in the what, submucosal what veins when it comes to the what, esophagus there. So for you to avoid that, according to pharmacological management, give them what, octreotide. Okay, it's going to be useful for important in what, esophageal varices. Although it also has other what, other importance. Apart from that, apart from what, esophageal what, varices. Okay, you need to know about that. What else apart from that? So apart from pharmacological management, what else apart from this? Okay, what do you know apart from pharmacological? We know that now it is what, surgical. Okay, surgical management. So let's just say that. So surgical management like what? So now if you look at surgical management, basically that should be the last option. Okay, after maybe this procedure, the pharmacological management, the endoscopic type of management, colonoscopic type of management has failed, then that's when you can go to what, surgical management. Like what? So let's talk about just few examples. Like what? Maybe if you want to remove the stomach, that is gastrectomy. Okay, or maybe you want to remove, maybe someone had maybe colorectal carcinoma like that, while you're going to perform at like the colon dissection type of procedure. Okay, colonic dissection. Okay, where you remove the part of the colon there where it has been affected by the cancer or by other what type of disease that affect what, that. Okay, you can do that. The last important thing is you need to do what, endoscopy and what. So let's say endoscopy and what, colonoscopy type of what, management. Okay, so where you do what? So where you do the banding. Okay, where you put the clips there. Okay, so that's why you can do under endoscopic and the colonoscopy management. Okay, so these two important procedures, they can help you in the what, diagnosis and also management. Okay, so this is a very, very important part that you need to understand. Okay, now that's where we end from, and make sure that you study more. All the best.